What if I told you that a healthy 21-year-old on birth control might actually have the exact same vaginal tissue chemistry as like a 65-year-old postmenopausal woman?
It sounds totally crazy, but
All
yeah.
right. Well, welcome to our deep dive. We are taking on a highly specific, honestly fascinating mission for you today, which is figuring out, can the contraceptive injection actually affect your vaginal tissue quality?
It is such a vital question. And, answering it requires bridging several completely different areas of medical research that, frankly, just don't communicate with each other as often as they should.
Okay. Exactly. So to figure this out, we've pulled a massive stack of research for you.
Oh, yeah. A mountain of it.
We're looking at everything from official healthcare guidelines from the FSRH and MedSafe to pharmacokinetic studies like the WCICH trial. Plus, we've got crowdsourced patient data from the Lowdown, which is a platform where users review their contraceptives.
And we even dug into the medical literature on genitourinary syndrome of menopause, or GSM, and emerging clinical treatments like lasers.
Right. And the premise here is that the contraceptive injection is incredibly effective, right? Like a 0.2% failure rate with perfect use.
Which is ironclad.
Yeah, it's amazing. But it achieves that by pulling a massive biological lever in the body. Okay, let's unpack this. Because to understand how a shot in your arm or, your glute affects vaginal tissue, we first have to understand what it does to your overall hormone profile.
Right. And that underlying mechanism is, well, it's really the foundation of everything we're discussing today. So the contraceptive injection, most commonly known by the brand name Depo-Provera, is what's called a progestogen-only method.
Okay.
And progestogen is basically a synthetic version of the hormone progesterone. So when you introduce this massive, continuous dose of this synthetic hormone into the body, it effectively tricks the brain.
Wait, tricks it how?
There's this communication loop between your brain and your ovaries called the HPO axis. Normally, the brain sends chemical signals down to the ovaries, telling them to mature an egg and, crucially, to produce estrogen.
Right, the normal cycle.
Exactly. But when you get the injection, the really high levels of progestogen signal the brain to just shut that communication down entirely.
Oh, wow.
Yeah. The brain stops sending the signal, ovulation is suppressed, and as a direct result of that, the ovaries drastically reduce their estrogen production.
So, the injection doesn't just block sperm or change the uterus. It, fundamentally alters the factory settings of the ovary.
Precisely. It really does. And to see the sheer scale of that alteration, we have to look at a major piece of clinical research in our sources called the WitchTH trial.
Right, the WitchTH trial.
Yeah, this was a really robust, randomized study tracking patients on two different types of injectables. So there was DMPA, which is the standard Depo-Provera, and another one called NET-N.
Okay.
And the researchers tracked the participants' blood work over time, specifically looking at a primary form of estrogen called 17-beta estradiol.
And what did the blood work actually show?
A systemic plunge.
Really?
Yeah, at 25 weeks of use, they found a 60 to 62% drop in systemic estrogen levels across the board.
Wait, a 60% drop? That is not like a minor fluctuation or just a bad week.
No, not at all.
It's a total overhaul of the system.
It really is. The trial data provides the specific numbers, and they are pretty eye-opening. The median estradiol plummeted to roughly 76.5 picomoles per liter for the DMPA group,
Wow.
and nearly 69.8 to be exact, for the NET-N group.
Okay, give us some context here. Why does that specific measurement matter?
Right, so a normal premenopausal woman's estrogen obviously fluctuates, but it can reach anywhere up to 1,500 or even approaching 2,000 picomoles per liter just before ovulation.
Oh my gosh, so dropping down to 70 isn't just, low normal.
No, it is undeniably in the postmenopausal range. When your circulating estrogen is sitting in the 70s, your entire biological system is practically starved of that hormone.
It's almost like, it's like putting the ovaries into a forced hibernation mode.
That's a great way to put it.
You shut them down to prevent the pregnancy, which is obviously the goal. But the unintended consequence of that hibernation is that the estrogen supply just falls off a cliff.
Exactly.
So if the systemic estrogen is suddenly just gone, what does that mean for the specific tissues in the body that rely on that hormone showing up for work every single day?
What's fascinating here is how incredibly dependent the localized vaginal ecosystem is on that daily, steady delivery of estrogen.
Okay.
To understand what happens when it disappears, our sources point us toward the medical literature on genitourinary syndrome of menopause, or GSM.
Because the injection mimics that state.
Exactly. Because the witch trial proves the injection creates this menopausal-like low estrogen environment, we can actually use the GSM literature to see the exact blueprint of how the tissue reacts.
I imagine it's not great, but walk me through it. How is the system supposed to work normally when it has all the estrogen it needs?
Okay, let's look at the physiology of a healthy, well-estrogenized vagina. In a normal state, the vaginal wall is lined with multiple thick layers of what are called superficial epithelial cells.
Okay.
And thanks to estrogen, these cells are constantly turning over. They naturally shed every few hours.
Oh, like skin cells exfoliating.
Exactly like that. And here is the absolute genius of the human body. When those vaginal cells shed, they release a complex sugar called glycogen.
And what does the glycogen do?
It serves one primary purpose. It is the main food source for the good bacteria living in the vaginal microbiome, which are called lactobacilli.
Wait, really? So the tissue is constantly shedding specifically to feed its own local defense system?
Yes, exactly.
Yeah.
The lactobacilli gorge on that glycogen, and as a byproduct of that, they produce lactic acid.
Oh, I see where this is going.
Yeah, that lactic acid is what keeps the vaginal pH nice and low, typically under 4.5.
And an acidic environment is naturally hostile to pathogens.
It's basically an invisible shield. Bad bacteria, yeast, things like that, they struggle to survive in high acidity. It's a perfectly balanced, self-sustaining ecosystem.
But it's driven entirely by estrogen.
Entirely.
Okay, so then you get the injection, the progestogen floods the system, the brain stops talking to the ovaries, and your estrogen levels plummet by 60%. How fast does that ecosystem collapse?
Well, the cascade happens very reliably. Without the estrogen signaling the tissue to grow and turn over, the physical lining of the mucosa thins out dramatically.
Because the cells aren't turning over.
Right. The number of those superficial shedding cells drops to less than 10% of what a healthy system maintains.
Which means the shedding virtually stops.
And with no shedding, the glycogen disappears. The food source is just gone.
Oh, wow.
So the lactobacilli starve and die off. Suddenly, the lactic acid isn't being produced anymore, so the vaginal pH begins to rise. It eventually crosses above 5 or even higher.
The shield drops.
The shield drops. The environment isn't acidic anymore, leaving the door wide open for outside bacteria. For instance, E. coli from the digestive tract can easily migrate and take hold.
Which causes infections.
Exactly. It drastically increases the risk of urinary tract infections, persistent irritation, and abnormal discharge.
But wait, earlier you mentioned tearing and bleeding when we briefly touched on patient complaints.
Yes.
A surface pH change and a bacterial shift don't really fully explain that, right? I mean, getting a UTI is awful,
Right.
but it doesn't cause your tissue to physically tear. Is something happening to the actual structure of the tissue underneath?
Yeah, and that is the deeper, honestly more insidious part of estrogen deprivation. Underneath that surface layer of cells is the connective tissue.
Okay.
And that tissue is maintained by cells called fibroblasts. Fibroblasts are basically the little factories that produce collagen and elastin.
Which are the proteins that keep things stretchy and firm.
Right. They keep the vaginal walls stretchy, thick, and firm.
And I'm guessing those factories run on estrogen.
They do. So when the estrogen drops into that postmenopausal range, the fibroblasts go completely dormant.
It just shut down.
Yep. The existing collagen fibers sort of fuse together, and the elastin begins to fragment. The tissue literally loses its structural elasticity. In medical terms, it becomes pale and friable,
Friable, meaning fragile.
meaning it damages under the slightest friction. The tissue is so thin and lacks so much collagen support that everyday activities, let alone sexual intercourse, can cause micro tears, bleeding, and severe pain.
Wow. When you lay out the mechanics like that, it's like, well, it's like having a high-performance self-cleaning engine.
Right.
Everything runs smoothly, then someone just completely drains the oil. The parts are all still there, but without the constant lubrication and maintenance, every movement causes friction, everything grinds to a halt, and the engine starts taking permanent damage.
That's a perfect analogy.
But here's where I get stuck. If the biological mechanics are this clear, if we know progestogen drops estrogen and low estrogen shuts down the fibroblasts and starves the microbiome, why isn't this the very first thing doctors warn every young woman about when she goes into the clinic to get the shot?
That is the crucial, somewhat frustrating disconnect we found when analyzing the sources. You have this stark biological reality on one side, but on the other side, There is a baffling hesitation in the official clinical guidelines to connect those dots for patients.
Let's talk about those guidelines because reading through the FSRH, which is the Faculty of Sexual and Reproductive Healthcare, their guidance document was genuinely confusing.
It is a study in clinical contradictions. If you look at the official summary of product characteristics, which is the manufacturer's own data sheet that comes with Depo-Provera, it actually lists vaginitis as a common undesirable effect.
Okay, so it's on the label.
Yes. But then you read the FSRH clinical CEU guidance, which is what doctors actually use to advise patients, and they actively distance themselves from it.
Yes.
They acknowledge that things like decreased libido and vaginitis are reported, but they explicitly state they found little evidence available to demonstrate causation.
So the official stance of the guiding medical body is basically a shrug. Like, we hear the complaints, but we don't have the clinical evidence to legally say the injection caused it.
Pretty much.
But then we cross-reference that official hesitation with the real-world data we pulled from a platform called The Lowdown.
Right.
And for you listening, The Lowdown is this massive database where thousands of real people leave incredibly detailed, verified reviews of their lived experiences with different contraceptives.
It's a huge resource.
It is. And out of 313 reviews specifically analyzing the injection, a staggering 42%, that's 132 people reported experiencing vaginal dryness.
42% is a massive clinical signal. I mean, when nearly half of your user base is reporting a profound functional tissue change, that goes far beyond a rare side effect.
Yeah. But let me play devil's advocate here for a second.
Sure.
Isn't crowdsourced data completely skewed by selection bias? I mean, people usually only go on the internet to write a review when they are absolutely miserable.
But it's true.
Nobody logs onto a medical site to say, hey, just letting everyone know my vagina feels totally average today.
Yeah.
So should we really be elevating angry internet reviews to the same level as the FSRH clinical guidelines?
It's a really fair challenge. Selection bias is always a factor in crowdsourced data. But you have to look at the volume and the specificity of the complaints.
Meaning what exactly?
They aren't just saying, I feel bad. They are reporting the exact mechanical failures, dryness, tearing, pain that align perfectly with the estrogen deprivation we just walked through.
Right. The biology matches the complaints.
Exactly. And furthermore, the Lowdown's own medical expert, a practicing GP named Dr. Fran, explicitly goes on the record on their platform to confirm the mechanism.
Oh, she actually addresses it.
She does. She validates to the users that the progestogen in the injection suppresses estrogen, and that directly causes the vaginal dryness they're experiencing.
Here's where it gets really interesting. There was one specific anecdote in the sources that I think just grounds this whole debate in human reality.
Yeah, the 21-year-old.
Yes. A 21-year-old user left a review saying she originally went on Depo-Provera to help manage severe IBS symptoms. Her doctor thought suppressing her cycle might calm her digestion.
Right.
And for the first 6 months, she said it was fine. But after 9 months of being on the injection, she developed severe vaginal dryness and a total, absolute loss of her sex drive. She's 21 years old.
It's devastating.
She went in for a stomach issue and ended up with the sexual physiology of a senior citizen.
And, I mean, this raises an important question regarding terminology. Why are the major clinical trials and official guidelines seemingly blind to what real-world doctors and patients are seeing every single day?
Yeah, how can the FSRH say there's little evidence?
The answer likely comes down to clinical terminology and the rigid parameters of what researchers are actually told to look for.
How does terminology hide a 42% side effect?
Well, clinical trials often track a condition called vaginitis. The suffix "-itis" implies inflammation, usually caused by a primary infection like bacterial vaginosis or yeast infection.
Okay, so they're looking for a bug.
Right. If researchers are swabbing a patient's tissue looking for a specific infection that causes inflammation and they don't find a pathogen, they code that as a negative result.
Oh.
They conclude there's no causal link to the drug. But in doing so, they are completely missing the actual condition, which is atrophy.
Wait, so atrophy and vaginitis are two entirely different mechanisms.
Entirely different. Atrophy isn't an infection you can swab for. Atrophy is a structural, functional deterioration of the tissue caused by a lack of hormones.
It's the dormant fibroblasts and the thinned out cells we discussed.
Exactly. If the trial parameters tell researchers to look for an infection, they just won't find the evidence of structural dehydration. Hence, the official guidelines conclude there's little evidence available to demonstrate causation.
That is maddening. They are literally looking for a fire, but the patient is actually dying of thirst.
That's exactly it.
The trial marks it down as no fire, completely ignoring the dehydration. Okay, so we validated the biology. The injection unequivocally affects tissue quality, and it causes very real physical discomfort for you or people you know.
Absolutely.
So if I'm experiencing this, my first instinct isn't to jump straight into adding more prescription hormones to my body. What do the sources say about the restoration toolkit? Is there an over-the-counter way to just rehydrate the tissue?
There is. And because the anatomy under the injection reacts exactly like it does during menopause, we can actually borrow the proven treatments used for genitourinary syndrome of menopause.
Okay, that's handy.
Yeah. First-line therapies are broken down into non-hormonal and hormonal fixes. The immediate non-hormonal step is using bioadhesive moisturizers.
I assume there's a medical distinction between a moisturizer and a standard lubricant?
A massive one. Lubricants are temporary, right? They are designed purely to reduce friction during sexual intimacy, and then they wash away. Moisturizers, like Silk or Rigel, are formulated differently. They are bioadhesive, meaning they actually physically bond to the mucin.
Mucin being the natural mucus lining of the vaginal wall.
Correct. The moisturizer adheres to the mucin and the epithelial cells. They act like microscopic sponges, actively pulling and retaining water in the tissue over a period of days.
Oh, wow.
And they also often contain lactic acid to help artificially balance that vaginal pH we talked about earlier. You use them regularly, say every 2 to 3 days, to continuously keep the local ecosystem hydrated.
Okay, so it's the difference between splashing water on your face when it feels dry versus applying a deep, penetrating daily face cream that repairs the skin barrier.
Exactly.
But let's be realistic here. If the fibroblasts are literally asleep and the collagen is degrading because of the estrogen plunge, a moisturizer is essentially just a Band-Aid, right? It's not waking up the cellular factories.
You're absolutely right. A moisturizer manages the symptoms, but it doesn't fix the root structural collapse. If the non-hormonal route isn't enough, the gold standard in the clinical sources is localized vaginal estrogen.
Which is a hormone.
Yes, a prescription treatment. It comes in the form of tiny dissolving tablets, creams, or a soft silicone ring like estring that sits continuously inside the vagina.
I can hear people listening right now tensing up at that idea.
I know, it sounds scary.
Yeah, because if a patient is on the contraceptive injection specifically for birth control or to manage something like endometriosis, won't inserting estrogen back into their body completely mess with their systemic hormones? Could it reverse the contraceptive effect?
It is the most common fear. But the medical literature is definitive on this. Localized vaginal estrogen is incredibly safe because it provides an ultra-low, highly targeted dose that stays almost entirely in the vaginal tissue.
How low are we talking?
Let me give you the math from the clinical data. If a patient uses a standard 10 microgram estrogen pessary inside the vagina at the recommended frequency for an entire year,
Okay.
the cumulative amount of estrogen their body absorbs is roughly equivalent to the dose of just one single 1 milligram pill of systemic oral hormone replacement therapy.
Wait, really? One pill's worth over a whole year?
Over 365 days. It is a true microdose.
Wow.
But because it's applied directly to the starved tissue, it's enough to wake up the local fibroblasts, stimulate new blood vessel growth, and thicken the epithelium, with virtually zero systemic absorption into the rest of the bloodstream. You will not interfere with the injection's contraceptive abilities.
Okay, so moisturizers and ultra-low-dose local estrogen are the grounded, established medical routes.
Yes.
But we have to talk about the final piece of the puzzle here because our sources included some highly controversial, modern, honestly sci-fi sounding treatments. I'm talking about energy-based devices in the aesthetics industry.
Yes, the devices. The clinical papers delve into lasers, specifically fractional CO2, and erbium-Y lasers, as well as radiofrequency devices like Thermova.
And the claim from the private clinics offering these really expensive procedures is that these devices induce neocollagenesis.
Which literally means the creation of new collagen.
Right. They claim the devices heat the tissue to stimulate collagen and elastin production without needing daily hormones or surgery. Now, when I was reading through the methodology of how these lasers work, it instantly reminded me of, well, you know when you aerate a lawn?
Aerate them lawn.
Yeah. If your yard is patchy and the soil is completely compacted, You drive a machine over it that literally punches thousands of tiny holes in the dirt, pulling out plugs of soil.
Oh, I see.
It severely damages the grass temporarily, but that trauma shocks the roots into growing back thicker, deeper, and stronger than before.
That is a very accurate visual.
Because the fractional laser is doing exactly that to the vaginal wall. It's poking microscopic thermal holes in the tissue to shock the body's natural repair mechanism into rushing blood and collagen to the area to rebuild it.
Yes, that's the theory.
It sounds like a brilliant hack, but I have to ask, is it actually safe to intentionally burn internal tissue like that?
That is the multi-million-dollar controversy. When you look at the highest medical authorities in our sources, they are pushing back incredibly hard against the aesthetic clinics.
I would imagine so.
It's true that some small, private studies point to histological evidence, meaning they look at tissue samples under a microscope and see that the tissue has indeed thickened after laser treatment.
Okay, so it does thicken.
Yes, but the major oversight bodies are sounding the alarm. The American College of Obstetrics and Gynecology, the International Continence Society, and most notably the FDA, have all issued stern warnings.
Yeah, I saw the FDA warning from July 2018. They explicitly stated that the effectiveness and safety of these energy-based devices for vaginal rejuvenation have absolutely not been established.
Exactly. The core problem highlighted in our stack of sources is that the studies validating these lasers are currently way too small, they often lack proper placebo control groups, and they are heavily sponsored by the very industries manufacturing the devices.
Which is a huge red flag.
Huge. But the most critical piece of pushback comes from a white paper by the International Continence Society. They noted that the histological changes the clinics are celebrating as healthy neocollagenesis might be a complete misinterpretation.
Wait, misinterpretation how? Thick tissue is thick tissue, isn't it?
Not necessarily.
Yeah.
The white paper suggests that the thickening might actually just be the reparative changes of a thermal injury.
Oh. Meaning, of course, the tissue looks thicker and has more cellular activity. You just burned it.
Exactly, it's inflamed.
It's swelling up and trying to heal a literal burn wound, which is completely different from actually restoring the long-term, healthy, natural stretch and lubrication of the vagina.
Precisely. The long-term safety data just does not exist yet. The risk is that creating repeated thermal injuries to force the tissue to swell could eventually lead to scarring or fibrosis over the years.
So you might end up with tissue that is thick, but rigid and scarred, rather than elastic and functional.
Right, which defeats the whole purpose.
So, what does this all mean? We started this deep dive with a very specific mission for you. Can the contraceptive injection affect your vaginal tissue quality? And the answer from the biology, the clinical data, and the lived experiences of patients is a resounding, undeniable yes.
Yes, absolutely.
By drastically lowering your systemic estrogen down to postmenopausal levels, the injection triggers a profound cascade of localized tissue changes. It starves your healthy bacteria, it spikes your natural pH, and it puts your collagen factories to sleep, leading to thinning, dryness, and severe discomfort.
And this is true regardless of whether the official clinical guidelines are too caught up in terminology to explicitly connect all those dots for you.
Yeah, if we connect this to the bigger picture, I think this information is incredibly validating for anyone experiencing these hidden side effects.
Absolutely. Because whether you are dealing with a progestogen-induced side effect at 25, or navigating natural biological menopause at 55, your anatomy reacts the exact same way to estrogen deprivation.
The biologist simply doesn't care about your age.
It doesn't. And thankfully, the foundational, scientifically proven toolkit to fix it, using daily bioadhesive moisturizers for hydration and ultra-low-dose local estrogen to wake those cells back up, remains exactly the same, and is proven to be highly effective and safe.
It is so validating to have the answers, but it also leaves you with something huge to mull over as we wrap up. Right now, there are millions of young women around the world using this injectable contraceptive.
Millions.
Biologically speaking, they are walking around experiencing a temporary, localized, chemically induced form of menopause. So here is a thought for you to explore on your own. Could studying their tissue responses actually unlock better, faster treatments for aging women?
That is a fascinating idea.
Right. Think about it. Medical researchers could track exactly how vaginal tissue degrades and then recovers in a healthy 20-year-old when the estrogen switch is flipped off and then deliberately turned back on again.
The data would be incredible.
Could the key to revolutionizing postmenopausal care and finally solving the genitourinary syndrome of menopause be hiding right now in the birth control data of 20-somethings? Thank you so much for joining us on this deep dive.